Welcome to the External Medicine Podcast. My name is Daniel Belkin, and I'm here with my co-host and brother, Mitch Belkin.
We're both medical students interested in non-traditional ideas and innovation. This podcast is our attempt to explore topics currently on the outskirts of medicine, topics not widely accepted by the mainstream, but that we believe merit a closer look.
This podcast is for educational and entertainment purposes only. We do not endorse any healthcare providers or treatments. Our views do not represent the views of any official organization or institution.
If you'd like to support us, follow us on Twitter at EXMedPod and sign up for our newsletter at externalmedicinepodcast.com/subscribe.
It's been a while since our last show. We apologize to all the fans out there who have been anxiously awaiting our next episode. We have recorded a few, so we're going to release a number over the next couple of weeks in rapid succession. But I guess there's a small announcement today. Match day happened in mid-March, and Mitch and I both matched into radiology residency programs. So after internship year, I will be doing my residency at Johns Hopkins.
Where is that again?
It's in Baltimore, Maryland.
Okay.
Do you know where that is?
Oh, I know where Baltimore is. That's where I'll be doing my residency. I will be doing my residency at the University of Maryland Medical Center, which is also in Baltimore.
Oh, nice. So I guess we're going to be in the same place. That's exciting.
Yeah.
All right. But enough about us. Who are we interviewing today?
Today, we are interviewing a radiologist, Dr. Ben White. Dr. White obtained his MD from the University of Texas Medical School at San Antonio before completing a radiology residency and neuroradiology fellowship at UT Southwestern. Currently, he's an associate program director at Baylor. He's also a prominent blogger at his website, benwhite.com, the editor of a nano-fiction website called Nanoism, and the author of 3 books, including one about student loans.
In this conversation, we discuss Dr. White's background, why he decided to go into radiology, his thoughts on radiology residency training and medical school education, physician shortages, blogging, and his nano-fiction project. We hope you enjoy this conversation, and now we bring you Dr. Ben White.
We're here with Dr. Ben White. Ben, thank you so much for joining us on the External Medicine Podcast.
Gentlemen, it is both an honor and a privilege.
Before we get started, do you have any financial disclosures?
So my only disclosure as such is that I have a personal website at benwhite.com, and it is a for-profit enterprise. So I do make money writing about and talking about various things indirectly through partnerships and through ads and whatnot.
We're going to be sure to talk to you a little bit about your blogging. But before that, we should probably talk a little bit about your background. So you're a neuroradiologist, you're an associate program director, you have a long-standing blog, you're also the author of a book on student loans and the editor of an online short fiction publication. So I guess my first question is, how do all of these interests coalesce, and how do you even have time to do all this stuff?
I think for the first question, I'm not sure. I think it's one of those things where you just acquire things over time. And if you don't, if you're not careful about how you curate your life, occasionally you just kind of get the baggage together. But, for me, a lot of all this started in terms of my, writing and editorial stuff is just trying to find a good balance for feeling creatively fulfilled during medical school. So when I was in college, I did all these interesting things, and you go to med school and you're like, I've gone from being this well-rounded person to taking multiple choice question tests every 4 weeks. And I just felt like something was missing during that process. And so a lot of my writing actually came from, the one and only New Year's resolution I ever kept. Basically, it was that I wanted to write every day, and everything kind of stemmed from that. And so all the writing kind of gets put into this avocation, side hustle, side hobby of mine that I've been, doing for many, many years as a way to kind of be level, right? I think everyone has different hobbies, and I've always really enjoyed having a generative hobby where I had something to show for my time. And then in terms of everything else, I like being a kind of what I am is a private-demic neuroradiologist. So we work at a group called American Radiology Associates, which is in Dallas, and we are what you'd call a hybrid practice model. So we are a physician-owned independent private practice, but we also have a affiliation with the University Medical Center where we have our own radiology residency, work with medical students. And so I sought out this job because it gave me the opportunity to work with residents and trainees and be in academics where I could teach and write and do the things that were passions of mine without necessarily being part of a rigid bureaucracy or having a pressure to publish in a way that did not meet my needs. And so I was able to kind of fold in my writing hobbies and other issues with this job, because this job gave me the flexibility to both be the teacher I wanted to be through my day job, but also have the time to do the writing I wanted to do on the side.
How did you get interested in radiology?
So radiology was really arbitrary. And I'll tell you, so when I was going through medical school, I was one of those people that felt like everything was fine. Like everything was cool. Like nothing was super amazing where I felt I had to do this one thing. And very few things were so unpleasant to me that I thought I could never do them. And so I was going through third year, and I originally thought I might be a neurosurgeon, and that did not feel worth it to me in terms of the singular focus I would have needed to have to do that well and be good for my patients that way. And so I was going through third year and I was trying to figure out what to do. I really had no idea. And I thought about doing medicine, and I thought about having to put off potentially another choice of fellowship. And it just was very difficult to want to do that. And so I was going through third year, and I had one of those random formative experiences when I was doing trauma surgery. And I had a patient that had like a big liver lac that went to the IR suite to get an angio, and they, saved the guy's liver. They embolized whatever was bleeding, and he did better. And while that actually was very boring to watch, it was a cool idea. And so I thought to myself, maybe I want to do IR. And of course, so I was like, okay, I'll do radiology. I'm going to do IR. And then, of course, I got to radiology and was like, actually, I kind of like diagnostics. I kind of like just, having a mixture where I'm not just doing clinical work. I kind of like the cerebral part with the coffee and the chair. And so I ended up pursuing neuroradiology, but it was one of those things where it was not well planned out. And if you had asked me as a first year, Ben, what do you think you want to do in medicine? I would have said, oh, I don't know, but definitely not radiology, pathology, or OB-GYN. And then here I am. So I was totally wrong.
Yeah, it's funny how many of the clerkships just completely subverted my expectations. I thought I wasn't going to like surgery at all, and I loved surgery. I thought I wasn't going to really like peds, and I love peds. And I thought I was going to really love internal medicine, and I ended up not liking it as much as I thought I would. But anyway, go ahead, Mitch.
So you initially thought that you were going to do IR after going into radiology, but in the end, you ended up selecting neurorads. How did you come to neurorads?
I think part of it is just because I think the brain is very interesting. And I think, so I was a neurobiology major in college, and I always thought I might do neurosurgery or neurology. I just always was very brain centered. And so once I got to diagnostic radiology, and I was leaning more towards being mostly a diagnostician and not a proceduralist, I really just was kind of drawn to the brain. I think the brain is a cool organ. I think it's one of those funny things where I think so much of what we like about medicine for many of us is not so much our preconceived notion. I think there are people out there who know they want to be an orthopedic surgeon or dermatologist, and they just knew that going in, and they put all their eggs in that basket, and they've been doing publications and everything they need to do in order to get there. Their journey is very well plotted. And for a lot of other people, it's kind of like very related to what your exposures are. If you're around good people and good mentors in good work environments, you could be drawn to or pushed away from a field just based on the personalities of people that you're around, or the economics of the hospital you work in, and all these other factors that are so kind of arbitrary. And so I think a lot of that stuff has to do with just almost like luck. If you work with a great team in a certain field, you're like, this field is amazing. And you get to residency and you're like, maybe it's not what I wanted. And I've had friends that thought they wanted to do a certain field, they matched something, and they're like, this is not what I wanted. And because I think it's very hard to actually know what it's like to feel like you're doing a job before you really do it. I think people, even students who are well versed in their fields have a very hard time knowing what it's actually like to feel like you're doing for a career, to actually know what it's like to do a job day in and day out every day for years and years. during school, you every 6 weeks you're changing your clerkship. It's a completely different experience than it is to really sit down, choose something, and then work and iterate on that same thing over and over again, basically forever.
Yeah, I'm currently doing a neurology clerkship. And if I had to, at the beginning of medical school, say, this is what I was going to do, I probably early on would have said neurology, because I just think it's very intellectually stimulating. And it seems like a lot of what you do on the sort of day-to-day basis versus what you imagine that you're going to do, being in the clinic versus learning about how neurons function and different areas of the brain, tend to be very, very different. So my experience, although I've really enjoyed being in the clinic, it's clear that that's not necessarily what I really want to be doing day in, day out. And interestingly, even like within neurology, I remember learning about epilepsy and being like, that is so cool. Epilepsy is so interesting. Movement disorders, not very interesting. And in the clinic, it's been exactly the opposite. I find the movement disorders much more interesting to work with, and epilepsy to be not very exciting.
I think it's interesting. I think the bread and butter of a field makes a big difference. And I think it's very hard to anticipate what it feels like to do that. And I think there's probably more intraspecialty variation in a job than there even is intraspecialty. So I think even if you're a neurologist or a radiologist, within each field, there's so much variety to what your job could look like based on what kind of patients you see, the practice environment you're in, what kind of things you're drawn to, that depending on your personality and your interests, there really is an incredible amount of variety you can achieve in any field. And so it is one of those funny things where I think if I had gone to a different field, it would not have mattered to me. I would have been perfectly happy doing a variety of things. I think I would have figured out what spoke to me everywhere. I think for so many people, especially people who are entering competitive fields that do not match what they want to match, I think it's one of those interesting things where so much people's identity gets wrapped up in the idea of what label they're going to have, how competitive they were for this field or that field. But ultimately, it's much more to do with how you function in your job that makes you satisfied in your job. So for me personally, as someone who kind of came to randomly, I'm going to be perfectly honest, like it was totally arbitrary. I think what makes me like being a radiologist is being good and getting better at radiology. I think showing up to work and doing my best to do well for the patients I interact with and the patients I'm reading for, and working with the clinicians I work with to hopefully help them do well for their patients. That part, it sparks joy. I think I could have achieved that milieu in a variety of ways. And I think the key is, no matter what field you choose, is to find a way where you can take ownership over that job, where you can feel the growth and appreciate getting better at something. I think that getting better and being diligent and getting cognizant and mindful of that process, that is the part that makes training not suck. And if you don't have that, you're just focusing on the hours you put in, the microaggressions you deal with, all the other stuff, that is much less enjoyable. And it can be very difficult, I think, for a lot of people to deal with that part of it, because there is a lot of punching down that happens during training. And so if you don't have that healthy approach, that healthy background, I think it's a really difficult time for a lot of people.
So what advice can you give to people who are interested in radiology or have already decided to become radiologists? Should those people be, learning about AI or informatics or data science? Should they be tweeting and blogging and writing a short fiction blog? What should they be doing?
It's funny. Whenever I interview students for residency, what I always look at is their hobbies and interests, because ultimately I'm much more interested in people who are complete, well-rounded, happy people than I am about the things they actually do. I actually don't care what your hobbies are. I'm just interested that you have hobbies and what they are. And when you speak about them, how do you sound? Because ultimately, most people applying for residency are already filtered, right? They're already doctors, they're already smart people, they can already handle the work. So what I care about are two things. One is, are you fun to work with? And two, more importantly, number two, will you be good at clinical radiology? Are you going to be there for your patients? Because ultimately, that's what residency is for. Residency is for you to practice being a doctor in a controlled environment so that when you're independent, you are going to do a good job and help people. And so for the clinical work, we kind of rely on, how you do in your clerkships, right? How you do medicine surgery, not because you're going to be a medicine or surgery doctor, but because they're hard rotations that kind of summarize a lot of medicine. And so if you're a good clinician and you're a good teammate on those services, then you're probably gonna be a good radiologist. I can train you to look at pictures, right? That's not the part that you have to be good at ahead of time. It's really, can you do the work? Can you show up on time? Be a hard worker, be a good teammate. And ultimately, are you diligent? And so I really care about attention to detail in whatever ways I can adapt that, whatever ways I can see that you have it. Because ultimately, for people who do what I do, my report is my product. What I do is look at the pictures and generate a report. And so if you have good attention to detail, you are someone who is going to look for your comma splices and have your grammatical stuff in line. To me, that means that you're also going to read the chart well and carefully and do all other stuff. And so when I work with my residents, my biggest pet peeve when they is what they don't do, right? Is when they don't take the extra time to look at a patient chart for the history. When they're not looking at the prior exams carefully enough. I want that kind of detail to go in, because otherwise you're not adding service to the patient. You're not going to add value to that patient's care. And so clinically, I'm interested in that. And then non-clinically, I'm interested in just, what are you interested in? Like, I think it's much cooler to have whatever your hobby is, whether it's, baking or cutting your hair, that you have approach that with vigor and you really enjoy it. Because if you are a happy, well-rounded person, chances are going to be a happy and well-rounded resident and doctor. I feel like people who struggle a lot with residency and with training are people who haven't getting gold stars on their resume for no reason, but it's been punching their cards to adapt their CV for what they think they need to have, and they don't have a support system, in their own self and in their family, right? It's like if you don't have things that make you happy outside of work, and work is not loving you back, then how are you going to handle that part of your life? And so, I don't really care what you do. I just think it's interesting when people have hobbies that they really are passionate about, no matter what they are.
Ben, how did you know my hobby was cutting my hair too much?
It's funny. So in the pandemic, it was funny. So I remember last year, it was like it was in a significant fraction of people's ERAS applications was cutting their hair. And I had to wonder, like, how many of these folks actually have this be their hobby versus just they did it one time because the pandemic had closed all the barbers, right? And so I remember I'd ask each of them, I was like, how's that haircutting going? And we talk about it. And yeah, out of all of them, they'd all done it once. Like one person actually did it routinely, and everybody else had just did it one time and listed it on ERAS, which to me is not the cool thing, right? Like if your hobby is, I'm into programming. Oh, what have you been doing? Oh, well, class was virtual this year. So during my block I had off, I did a Python course online. Okay, it's not really your hobby. If you did a 2-week course online, that's more like filler for your CV, right? So again, as a hobby, like that's BS, right? Your real hobby is like, I love to read. I read tons of books, and here's the things I'm interested in. If I say, "Oh, you read what do you read recently?" and they go, "Oh, I read this and that," we have a discussion about fantasy novels. That's fun. If the hobby was, "Oh, I'm into AI," "Oh, what's that mean to you?" "Oh, I did a course online on Coursera." What you learn from that? The AI is really cool. Wonderful. Like we really made some serious progress in this discussion. So
So you are an associate program director, and I have a couple questions here because I want to get your insight into radiology education. If you were to design your own residency program from scratch in order to maximize educational value, what would you do differently than currently exists?
So what I would say is that in most programs, most radiology teaching happens in two ways. One is at the workstation, kind of one-on-one, reading out cases. And that's a really important part of learning. The problem with that is twofold. One is that in many cases it's at the mercy of what shows up, right? So if certain cases show up and other ones don't, you only are going to discuss the things that are showing up. And so you're kind of at the mercy of, the kind of practice setting that you work in. And then secondly, a lot of lecture, right? A lot of lecture is very passive and didactic. And so if I were designing a new curriculum, I would focus on two things. One is the non-workstation learning, I think, should be much more interactive. And I think we should be really leveraging a lot more online platforms. I think there's a lot of great content out there and a lot of great interactive models people can be building where people can, basically read virtual cases, right? We have a lot of virtualization we use in other fields. We don't do enough of that in radiology. Radiology is the most suited field in all of medicine to do simulated work, right? So you could have someone log in and read cases as if they were reading them live in the hospital, but they're all old cases. And so you can test a resident to see if they've actually learned what they need to learn in a true native radiology environment, even if the cases aren't live. And so most places are very focused on what's happening in the hospital that day. They could be focused much more on making sure the resident is able to handle a broad swath of pathology based on the kind of set cases. And so there should be much more of this kind of surgical center type learning where people are using the fake tools. We should be doing much more of that in training. And then I think one thing that a lot of places do that we don't do much in my program, but a lot of places do, is they kind of treat junior trainees like scribes, where a resident will sit with an attending will then tell a resident what to say, and the resident is good or bad based on how well they transcribe what the attending says, essentially. And I think residents are doctors because they are. And so I think any model where I'm judging how good you are based on how well you read my mind or how well you take notes and transcribe what I say, I think is missing the point, because the goal of residency is for you to be gradually getting better at radiology so you can be an independent practitioner, especially on call. If you have a program with independent call, is to be safe and ready to practice by yourself at night. And so my goal is I want to see how well you actually practice radiology. I want to see your report. So when I work with residents, I have them read the case and send me their report. And then we go over their report together, and I catch their terrible grammar, I catch their awkward word choices, the bad organization, everything. And we talk about their actual product, because to me, that's the purpose of the training. I don't really care how well they say what I want to say. I want to see what they want to say. I think more training needs to be about that, about seeing the actual product of a resident and giving them feedback in the moment on that. A lot of programs don't have a lot of that. And so I think we need to do a better job of evaluating the true work of a resident during the day, and do a better job of leveraging the incredible breadth of radiology available online and in our kind of packs to give residents a better simulated training environment where they're going to see a broader swath of clinical care that they might otherwise see during the day work.
So one topic that you've written about, I don't know about extensively, but you've written somewhat about it on your blog, is the importance of independent call, or having as much independent call as possible, all other things being equal. And a lot of programs have moved away for legal liability reasons. I guess I'm sort of curious your thoughts on the future of radiology, and how, do you think some of those restrictions should be ruled back? Do you think that the online platforms that you were describing could take the place of independent call, or do you think that really making independent decisions is ultimately what a radiology training program is for?
I don't think it's going to go back. I think the progress there, for a variety of reasons, is one directional. And I think there is an argument for, supervised call, in particular, just because it makes the throughput in the ER faster. And that's an important metric for hospitals. And so it's not going to go away. So I think that's true. I do think there is something lost there, is that there is no amount of online anything that's going to take the place of the psychological weight of making independent decisions. And so when you think about other clinicians, you think about, surgeons or medicine doctors or anyone else, nobody everyone has a degree of greater responsibility. Whereas an intern, you have more supervision. As you get more mature, you have less, because you are more senior and you have more experience. And so the problem with not having independent call is that it makes it so that you have a barrier to voicing your thoughts, essentially, all the time throughout all your training. If you were to come out there and read a case that's very challenging, and someone else is reading behind you by half an hour or an hour, either you don't make the call at all because you're going to be overread in half an hour, or if you do make the call and it's a weird call, the ER doctor will just talk to the attending or wait for the attending to read, and they'll say, whatever, prelim, who cares? And therefore, because of that, the weight of independence is not really there. And so all you're doing when you do that is you push back that kind of psychological growth to attendinghood. And so what I see is, when I see people who oftentimes who don't have independent calls, it means that when they were junior attending, they are less confident, because ultimately they've never been responsible before for any amount of time for that patient care. And so it's not that you can't eventually become a good radiologist, or that you can't be a good radiologist up front. I just think it's very hard to replace that growth. And I know for me personally, and many of my colleagues, that it was that independent call, that fact that you were kind of on your own and responsible for, potentially, 12, 14, 16 hours of care, that made you really work hard, made you really study, made you really practice and take care, because you knew that your report was impacting care. People were going to be sent home from the ER. If you called it normal and they were not super sick, they were going to go home. And if you were wrong, they're going to get called back. I think that part of that is really important. I think without that, it's very easy to feel like what you're doing doesn't really matter. You don't really have an impact. And for some residents, not all, that allows them to coast kind of the entire time. And they get to the end of training, they become fellows or attendings, and they say, oh, this feels different. And they struggle to deal with that. I remember I had attendings when I was a resident who would be junior attendings, and you would say, my report would say, like, acute uncomplicated appendicitis. And then they would end it and say something like, there are inflammatory changes around the appendix compatible with acute appendicitis. Like, they couldn't even say appendicitis. They had to hedge it and qualify it in some way because they felt so uncomfortable just saying a diagnosis. They felt like uncomfortable, like intrinsically, deeply uncomfortable with just the core part of our job, right, of making the call. And I get why that happens. And so I do think it's a really important thing to have ideally, but it is, I think, ultimately going away. And so I think the key for a lot of residents is, if you don't have that in your program, is how do you develop a situation where you are forcing yourself to be responsible for your own growth, because you're not going to be forced to in that way. And so it kind of puts the onus on you, I think, a little bit more to take your training seriously and really make the most of it and kind of act as though you are independent and that you really do matter no matter what, and that you're going to impact patient care a ton, even if maybe, depending on how it's practiced, you might not be. And it depends on the program. There are a lot of different ways to supervise residents. So there are programs out there that have attendings in the room with residents the whole night long. There are programs that have attendings somewhere far away, kind of reading at their own pace. There's a pretty broad swath of that out there. So there's a lot of different ways to be not independent.
Another topic you've written about recently on your blog is the private equity model in medicine. So my question to you is, what is the private equity model in radiology, and what are your thoughts on it, if you could flesh those out?
So private equity is basically a funding model for how to run a business. And there are lots of different ways to do corporate medicine. Basically, this is kind of one of them. It's the most recent one, and so it's been in the news a lot recently. But essentially, what they're doing is, in terms of what actually happens on the ground, what they're doing is what a lot of corporate practices have done, which is basically to say that when you have a radiology group or any other kind of medical group that's been bought out, is that those people are now employees in a practice that they have no control over. And because the owners take a cut of the revenues, they have a reason to want to have the doctors working harder than they otherwise might be. And so there's a profit motive that's different. And even keeping all work the same, because they take such a big haircut on top of the revenues, it forces operational changes in order to make everything kind of work out financially, right? So if you have a group that was making a certain amount of money and they sell the practice to private equity, those people all now make less money doing the same amount of work. And so obviously, if you are the partner who sells that practice and makes a big cash, buyout at the very end, that is fine for you because you made a lot of money and you can then go retire when you're done. But for everyone who's young to the practice, that doesn't really work out because now you are working super hard, but making less. And so there's always going to be a pressure to produce that is probably counter to what is good for patient care. And so one of the issues that's come up a lot in radiology, for example, is that because of how many practices have sold out, there's a lot of instability in the workflows because a lot of these groups are not very fun to work for. There's always a pressure to read more cases. And what oftentimes happens is that people who are not partners in the practice, who did not benefit from the sale, will quit the practice because the practice is no longer what they're looking for. And then the practice is then understaffed in some way. And so now everyone has to work harder to get the work done because ultimately patients are still being scanned and there's still work to do. So you have more and more work to do for fewer and fewer people. The job gets worse and worse and worse, and the group is unstable. And so right now we're in a phase in a lot of these buyouts where the buyouts are still vesting, what it's called. So people have sold the practice, but they have not gotten all the money for the sale yet. It's oftentimes, let's say, a 5-year vesting period. And so the next couple of years, we're going to see a lot more of these practices kind of mature in that sale. And so a lot of those people who made lots of money in the sale are going to retire or leave their practices because they're no longer forced to stay. And when that happens, it's going to be a very busy and complicated time in the field. And so I think there's just ultimately a lot of complexity there, and kind of, ultimately every time you add a middleman to a practice, you're adding complexity. If that complexity is not adding any value, then it's probably not worth it. And ultimately all these middlemen type situations with the PE model end up just making practices less efficient and more expensive to run, with the doctors making less money and therefore having to work harder. And I think most people would do a better job having the control and autonomy and able to practice the way they want to practice and reading at a volume that they're comfortable reading in, as opposed to reading at a volume that someone else wants them to read. Because ultimately, if you are reading tons per day more than you want to be, you're probably not doing the best for your patients. And that just makes me very uncomfortable.
So just to clarify, some of the alternatives to the private equity model would be an independently owned partner-based practice, or what would be a series of alternatives to that model that you just described?
Yes, the main alternative is, independent practice. And so, like, for example, my group is a independent practice. So it's a radiologist-owned private practice. Over 100 of us that are in the group, and more than, I think, 70 partners who are shareholders in the group. So we own the group. We have the contracts. We determine how many folks to hire, how many people we need to staff it, right? So we can say, oh, there's more work to do. I'm going to hire more people to do it. We'll make less money, but we'll have a better work-life balance, for example. We can do that. We're not going to have to say, okay, well, if we make less money, then we can't survive. We can all choose to do that, right? If you're in a PE type practice, they have to get paid. The people who now bought the practice, take the money first. They take a cut on top. And so you don't necessarily have the ability to handle the workload in the same way. And so that is, I think, the most flexible model in terms of practicing medicine, is to be independent, because it allows you to do what you want to do. That being said, there are plenty of bad independent groups too, right? You can say, I want tons of money and work too hard and be a bad doctor. I mean, that does happen. So you're not immune from bad care if you're independent, but it allows you to practice on your own terms when you're independent. The fact of the matter is that, 20 years ago, you would say academics would be the alternative to private equity. But the fact of the matter is, a lot of academic practices are now very corporate in a similar way, because, again, it's still a third party. The third party here is an academic medical center, but they still have bills to pay. And so let's say you're a big institution and you want to have a lot of research. Well, what do? You have your radiologist get paid less, take the money they generate, and you give that to researchers to do research. So it's not a different model. So instead of going to a profit center for, a corporate-owned private equity group or a publicly traded company, you're going to an academic place. It's not like it's not being taken away. But overall, that is the issue with any third party. Whenever you're an employee, if your employer is malicious, it's going to be a bad job. So unfortunately, I think, historically, I think most academic jobs would have fallen into a much better category. I think nowadays, a lot of them are kind of more part of these big health networks, where unfortunately the clinical income is a really big driver for a lot of the finances. And so I think it's harder and harder now to find a job where people are doing right by the patients. But overall, I mean, I would still say academics is probably a much healthier environment than most corporate practices. But yeah, the clear way to practice what you want to practice, right, is to be independent, because then you and your partners who you work with determine how hard you want to work, how much you are willing to work to get paid a certain amount of money. It's all under your control. Any other situation is you have someone telling you how many RVUs you need to do per day in order to get paid. So say, oh, if you don't read X number of cases per day, then you didn't do your job today.
So is the main difference between private equity and other models that you're optimizing for one thing, that is profit alone, versus optimizing for other things that might be valuable to the people in the practice, like work-life balance, or maybe thoroughness or prestige among other doctors in the field? And because they're only optimizing for one thing, it ends up not being optimized on those other areas.
Yeah, there's an issue in medicine where people are really happy to count things that are countable, right? So an RVU, relative work unit, is how we get paid by Medicare. It's kind of how everyone gets paid for fee-for-service, right? And so if you are focused on RVUs, and what you're focused on is a measurable unit of work output that results in money. And so things like, let's say, calling a ordering provider and talking about a case does not pay anything. Talking to a patient does not pay anything. Going to tumor boards does not pay you anything. And so if you are part of an employed group or a PE-owned type group, what really happens is that everything that you do is a cost center for that group, right? Their biggest expense is paying your salary. So the more money you generate for that practice, the more money they will make relative to how much they pay you. So the goal is always to pay you the least amount possible and to make you work the most amount possible within the confines of the market. So right now, the market's pretty hot because there's a shortage of radiologists, for example. And so they're not able to be super aggressive in how much they make you work versus how much they pay you. But in other markets, that might not be the case, right? And so the situation is, if you want a long-term stable job, you have to be in a place where there's going to be everyone's interests aligned. And so right now, a lot of people are perfectly happy to produce shoddy work and do a bad job as long as it's high volume, because you're counting the volume, you're not counting the quality. And while Medicare and some other organizations have tried to pretend that we can somehow quantify quality, it's very hard to do. It's very, very hard to do, especially in radiology. And so ultimately, people aren't really counting the quality, they're really counting the quantity. And so that is basically the metric of these practices. And so, yeah, if you are only optimizing for number of work units produced per person you employ, that's going to create an incentive to make that person basically squeeze as much as humanly possible until they quit. And if you can hire someone to replace them, that's fine. Right now, the market's a little bit, hot in that way, and so they can't squeeze too hard because people just quit and they can't hire. So right now, it's not the worst to work for some of these groups, but it certainly could be in the future. And certainly, even now, most of them are understaffed, and so they are, because of just by the metrics of how much work there is to do, they're all working harder than they need to be working. And that, I think, is not sustainable. There's a recipe for burnout, and ultimately results in not very good care.
So now let's move on and talk a little bit about medical education. The classic model of medical education is something like 2 years where you learn your biochemical pathways and you do anatomy, etc. And then 2 years of being in the hospital where you learn how doctors work. And I would say, probably over the last 15 years or so, the internet has started to change the first 2 years in particular pretty drastically. So now most medical students learn more from watching a bunch of cartoons like Sketchy or Pixarize, which are like optimized mnemonics. They pay like $100 for a year and they learn more doing that, or Boards and Beyond or Pathoma, these other video-based internet services, than they do in lectures actually at their medical schools. So I guess I'm curious, like, if medical students can learn pretty much everything that they need to for the first 2 years, let's give them a few months of anatomy and a few months to practice so they're ready to actually go into the hospital. But the rest they could, in theory, just do at home for a few $100. Does that mean the current model of medical education is outdated? And if so, like, or just in general, what are your thoughts on that?
Absolutely. No, I mean, even when I was a student, back when we only had UWorld, I thought that the first 2 years could be a correspondence course, basically, right? Is that, the number of things people were actually offering that had true value that you cannot replace by self-study or an online resource were very low. When you think about medical training in general, we have this kind of saber rattling type contest where we talk about, how long someone's training is as being a proxy for quality. So if you train X number of years and you're going to that means what you do is hard to do, right? And if your training is short, it's not. And doctors are better than PAs or NPs because training is longer. But the girth of training is not what makes it good or not, right? The quality is independent of the quantity. And I think we've just allowed the length of our training to serve as a proxy for how good it is. And it's very depressing, right? If you think about it, most of the basic science kind of stuff could be in college because most of the pre-med stuff is useless, right? So pre-med stuff is mostly not useful. And half of the stuff that basic science is not that useful. So most of that could even be in college, could be pre-med. And then medical school could basically be the actual doctoring part, because right now, the first, year and a half, 2 years, depending where you go to school, is kind of nonsense, right? It's learning, but it's not necessarily provided by the institution. And a lot of the schools have moved to PBL and TBL type practices, I think, in order to seem like they're providing value, because like, hey, it's small groups, we have sessions, they're in person. But the fact of the matter is, the data behind that is pretty mixed at best. It's not like PBL solves the problem of lecture and makes education magically more efficient. It's just nonsense. It doesn't do that. And so I think ultimately these schools are trying to justify their very high tuition counts. But so the first 2 years are kind of nonsense. Third year, obviously very important. And then fourth year, especially historically, a lot of it's just interviewing for residency, right? So if the last year, and then after that, if you're doing electives and stuff, it's very easy to basically see no patients your second half of fourth year. Post-match fourth year is very much a senioritis type picture. And so there are a lot of medical students out there who basically the first 2 years could be correspondence course. The third year is absolutely critical and important. And the fourth year is basically a wash. You 2 months of sub-Is or whatever, take step 2 CK, interview for a few months, take some electives and whatever. I mean, out of the 4-year process, maybe a year and a half is truly core value provided to doctors. And that is very depressing. What incredibly expensive and time-consuming waste of time to spend all that time and all that money basically just kind of inefficiently feeding the academic monster. You know what I mean?
Yeah, and not every clerkship during third year is equal. So the ones that actually give you more autonomy are so much more valuable for learning and understanding medicine than the ones that are basically trumped up shadowing. Like some of them, you really don't do anything. You just watch the doctor come in and do the thing. They don't let you do very much. And then you look at your watch and wait to go home so you can study for the shelf.
So it's
So
fascinating. I think it's one of those interesting things where, especially now that step one is pass fail, so much of clerkships now is going to be even more of, oh, can I help you out in any way before you go home kind of questions, because even more than it was before, even before it was all about, the shelf exam score was a lot of what determined your grade in many schools. And so ultimately the clerkship was mostly about studying for the shelf exam. Now step 2 CK is going to be even more important because of step one going pass fail. I think we're going to be even more in a world now where the patient care part of clerkships, which is the whole point of medical school, will now become subservient to the studying part of third year, which is crazy to me. I mean, I think it's kind of funny. When I was a student, I was in a very hands-on medical school, which was great. I remember they made a rule change when I was a student that for every year until my year and went halfway through my third year, that when you wrote a note on surgery, that was the note for the patient that day. The intern would co-sign the medical student note. The attending would co-sign the intern's co-sign of the medical student note. There was one note. The only note for that patient that day was a medical student note. So your note mattered. What you did mattered. You were a part of that patient team. You weren't just doing a song and dance routine. You were part of the care. That makes all the difference. Then, let's say when you're on medicine nowadays and you see your patient and you write your super long note with your 20-point impression and your everything like that, and it gets buried in the EMR and no one looks at it, and you're not even sure if anyone's looked at it. And if they do look at it, they're like, maybe look at a handful of your notes over the course of the whole rotation and tell you that they're bad, basically, and then you move on. And so, how could you feel like you're part of the team, and how can you take it seriously and not just view it as performance art if you're not actually part of the care? And this is why I think independent call is important. Same thing. I think people take this stuff so much more seriously and learn better and grow more when they're doing work, like actual work, not just doing a facsimile of work or pseudo work or the notion of work, but actual work. I think people, if you're going to be in the hospital for 10 hours a day, you want to feel like you're doing something. And because medicine has so much paperwork now, so much of it is in the EMR and not at the bedside, if all we're doing is doing notes all day long and your notes don't matter, it's just, how depressing is that? And you're like, I missed my friend's wedding. I missed this and that. I can't, you can't live your life like your friends are who are not in medicine in your 20s, right? You feel like you're sacrificing all this stuff. And for what? So you can take multiple choice tests and write some long notes no one's going to read. That is not fair to people who have gone through this gauntlet of a process to become doctors. It's very infantilizing, frankly. These are people who are adults. Like, you guys are adults. We're all adults here. And you treat the students like they're basically, I don't know, paid guests.
One thing that's became clear in medical school, my underlying assumptions about third year clerkships and third year rotations was that it's better to do them at an academic tertiary medical center because you're going to get exposure to all the most interesting cases. But through my clerkships and rotations, what I actually learned is it's much more preferable to be at a community site where they're a little bit short-staffed because they actually need you, and the work that you do actually matters, and the end result is ultimately more learning. It's interesting, we were talking a little bit earlier with radiology, the importance of independent call, and as a medical student, the amount of independence personally that I've experienced are where I've learned the most, because when the decisions that I make matter, what I put into my note matters because this is the note for the patient, I learn more, I try harder. And I think that that's something that's been very much overlooked in the process of trying to make medicine safe. And by safe, I mean bureaucratically stipulated as safe. Obviously, safety is very important, but that fourth year medical student, third year medical student in a year or 2 years is going to have an MD after their names, and the decisions that they make are ultimately going to have to matter. It's likely best for them to do some amount of that learning prior to getting the 2 letters after their name.
One last question on doctordom before we move on to blogging briefly. So the US is having a physician shortage. There are all sorts of complex regulatory and non-regulatory reasons for why we have a physician shortage. I'm curious if you have any thoughts on the proposals for alleviating that shortage, either by loosening restrictions on the immigration of doctors from other countries, or increasing residency spots, or expanding the number of medical school slots, or increasing the number of nurse practitioners who are able to do some aspect of the physician's jobs.
So I think there is absolutely a shortage. And what happens is the path of least resistance is just to allow mid-levels like NPs and PAs to do more. That's what's happening right now. So right now there's a shortage and they're cheaper. And so there's been a general push towards greater autonomy for those non-physician providers over the course of time. And so taking no new action, that's what's going to keep happening. We're going to have more and more of that. And being a doctor will be a kind of a luxury type, I think, process where, certain fields will be dominated by mid-levels and certain fields will be persistently done by physicians mostly. And that's kind of a weird system, right? I'm not sure I like that very much. I think one of the easy things to do is to add more residency slots right now, because we know that some doctors are going unmatched. And so that's, clear, easy thing to do is add more slots, not just in residency in general, but in the fields we need doctors in, right? So we need more primary care slots and more things like that, and probably not so many in certain fields that are more specialized. So I think that's one solution. I think another kind of solution is also to streamline the process a bit, right? So we talked about the inefficiencies in pre-med medical school. We didn't really touch on residency, but the same thing applies there. And one thing that's probably important to consider is that because in many states now, the non-doctors are able to practice independently. Let's say you can be a psychiatry NP or a primary care NP from an online degree at this point now and practice independently and have your own practice and do all that kind of stuff in many states. Does it really make sense for us to, again, use quantity as a proxy for quality for how we practice medicine? Do we really need to have every single residency be 3 years plus? For many, many decades in America, after internship, you could practice independently. You didn't have to do 3 years to be a PCP. You could just be an internist after a year. And so perhaps we should be looking more at models like that, because our kind of colleagues in healthcare who are not doctors are already doing those things. So again, we want to provide good quality care, but it's kind of a false argument to suggest that you can only learn healthcare and only get better during training. And once you're done with training, you are a danger to yourself and others, and you can never get better, right? You can never learn outside of training is ludicrous. And so training is really there to provide you a floor for independent practice. Once you are safe enough to be independent, your training can basically be over, because that's what it is for everybody else. And so I think we need to be taking a very hard look at how long training is and how long this process is to achieve a reasonable floor for people to practice independently that is not just artificially long because it's been long in the past. I think we have a lot of fat to cut that we can make things a little bit better. And certainly, again, if residencies were shorter and you had the same number of spots as you normally do, then you could obviously get more residents through in the same amount of time. So I think there's inefficiencies at every single level that could be taken care of. I think are very important. I think, frankly, especially with medical student debt the way it is, and with kind of the level of burnout it is, we have a lot of medical students and trainees who are already looking for an exit strategy while still in training. It's been a huge, massive kind of almost like a bubble of side hustles and fire movement kind of stuff. People just trying to leave medicine before they even get out into practice. And to me, that means that we need to work on this process, because if people are in training and already want to quit and are looking for a way to practice for 5 years and then quit, it's like, well, that's not going to help the shortage either, right? So we need to be working at every single level of the process to make this a career that is sustainable for everybody, and not just, a badge of honor for suffering through it.
What is the advantage of writing in your own name as opposed to using like a pseudonym? I think this is something that Naval Ravikant has talked about a little bit, the benefits of putting yourself out there and attaching things to your name. What do you feel like those benefits have been for you?
Yeah, I think that's a big part of it. And for me, honestly, it was kind of an accident, is that most of my writing originally was derived from creative writing. I was actually writing like fiction, short stories kind of stuff. And so I was writing under my own name. And so my original website was mostly a platform for me to discuss like fiction and share my writing. And then it developed kind of organically into more blogging over time. And so I didn't choose to do it on purpose that way. It makes things harder because it makes you have to stand behind the writing you do, right? Because the writing you do reflects who you are as a person out there when you use your real name. And more people are going to know you as this digital entity as Ben White, as opposed to the actual me person in real life. And so I think the benefit is that it forces you to, I think, be a better citizen to a certain extent and to think through your processes more, right? Because every time I write something, it's not just, is this good or not in some qualitative way, but also, is this reflecting me, the way I want to be, the person who I want to be? And every kind of post you write is basically a vote for that identity. And so I think when you're writing your own name, you're forced to really consider that identity routinely and stand behind it. It also means that if it's good, obviously people, will know you by that name. That means you could get some, currency, some kind of street cred, I guess. To have that on your own name is a good thing. But I think also it just means that you are going to be, I think, a better person online, right? I think a lot of the anonymity it's important to have some safe spaces online for people to be anonymous, but I do think it allows people to be much more trolly than they otherwise would be. And so I think for me, it's important to really hopefully be a force for good online. And part of that is because I know it's me to continue to be me all the time and not just something else. I think, let's say for a lot of people who do kind of writing as a business, for example, if you are writing under a certain platform that is based on a certain concept, let's say about personal finance or something like that, at that point you are writing in service of that idea and not necessarily as a reflection of yourself. And they're both good. Not like one's bad or one's good, but I think for me personally, it's better for me to be that person.
What is your most controversial blog post?
Ooh. So I don't know if I have controversial ones per se. I will say that probably the most trolly that I've been personally is I occasionally punch up at the American Board of Radiology, for example. I think that a lot of the organizations in medicine, a lot of the acronym people, are not always acting in service of the people they serve. And that's including, AAMC for medical colleges. That's true of a lot of, ACGME kind of stuff for residency. And a lot of the various American medical boards are in kind of the same umbrella. I think a lot of people are probably well-intentioned, but not necessarily doing the right thing. And so I as a radiologist, I oftentimes will pick on the ABR a lot. And I know some people don't love that. I know that I irk some people with that stance, but I do think that, ultimately, kind of like Washington Post style, that, democracy dies in the darkness. I think you have to sometimes just shine light on things and talk about them and hopefully continue the narrative so people can have that discussion. And it's just not just, fading away. I think when people limit themselves to social media and Facebook and whatnot, the half-life of those posts is so short and they're so oftentimes anonymous that there's really no meaningful staying power than it is of someone who actually has a website that's a permanent, platform with a real name, says this. Like, I'm willing to be quoted in, journals and periodicals about my stance. That's a very different thing than, user XYZ says this on Twitter. It doesn't really have the same kind of weight.
You started something called Nanoism. Can you tell us a little bit about what Nanoism is and what was the impetus behind starting it?
So Nanoism is an online-only literary publication for Twitter fiction. And Twitter fiction in this context means stories that fit in the size of a tweet. So, and this is like tweet old school style, 140 characters or less. So about 25 words at the high end. So very, 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 very short stories. And so it derives from the term nano-fiction, which I created as a kind of play on words because there's a term called flash fiction, which is short stories, very, very short stories. And there's microfiction, which is like maybe 100 words, 200 word stories. And it's even shorter than that. So I changed the prefix game, made it nanofiction, nanoism. And why that happened is kind of weird. But the short story is that as part of this 2009 New Year's resolution I had, where I wanted to write every day, I had just read an article in the New York Times about a Twitter fiction at the time. It was because a journalist at the Times had written what he called a twiller, which is a portmanteau of Twitter and thriller, which is cringeworthy. But he had written a kind of serialized story, kind of in the vein of the movie Memento. And it was not very readable. I didn't actually enjoy it. But he had written a story on Twitter. And these people were acting out the characters of Mad Men online as well. Like, Don Draper was a character on Twitter who was tweeting as if he were Don Draper. I thought to myself, this is all very well and good, but none of these things really capture the spirit of Twitter, which is people's very, very short tweets. And so I thought to myself, I could write a Twitter story every day because that's very short. Who doesn't have time to write a tweet? And so as a kind of creative enterprise, I was writing Twitter fiction on a daily basis. And after a few months, I thought it was so kind of fun. It was very enjoyable. It forces you to write, a story or a self-contained idea in that length of time. That length of work. It really forces you to be concise. It forces you to kind of distill down an idea into its like core nugget. And it really lets you open up your eyes to the world around you, looking for stories, looking for the stories and everyday things that might make for a good thing to share. And so I thought it was really a great creative endeavor and good practice for writing small and being concise in your thought process. And so I thought I would start my own Twitter publication. And I wasn't the first person to do this. I mean, there was actually a science fiction based one. It was called Thaumatrope that is now long since defunct. And it was all, science fiction, fantasy, horror kind of stuff. So I thought I would start the first literary Twitter fiction publication. So it was all kind of just not genre, not speculative fiction, just whatever. And I paid. So I paid professional rates, which in the professional rates at that time were 5 cents a word. So I paid $1.50 for each story. And so I was the first literary and paying venue for Twitter fiction, I think, in the world, 2009. And it's been going ever since. We have almost 1,000 stories now published on, so in the beginning it was 3 times a week, and that became unsustainable. So now it's been once a week for many years. And so that's what it is. It's a very, very strange, very, very, very niche hobby.
Do you have any favorites offhand?
There's one I can't remember offhand, many, many years ago. And the story was the Tilt-A-Whirl was closed that year. Sorry. The Tilt-A-Whirl was closed for repairs. So she didn't get to see her son that year. And that was the whole story.
So I guess we'll move on to some rapid fire questions. The first one is, what are 1 or 2 important papers in the field of radiology that you feel like people outside your field should be more familiar with?
So the most important one, I think, actually, now that you mention it, is going to be a paper that came out relatively recently about contrast media safety. And so for many, many years, people thought that oxygenated contrast we use for CT scans, cause kidney injury. And the risk of that is very much overstated. So there are a lot of people out there, patients and providers, who think that they cannot get contrast for a scan because of the risk of kidney injury. And while kidney injury may exist, it's certainly, the risk is very low in most cases. And so most people can get contrast, no problem. And so the 2 papers I think are important. There's one about CT contrast, in which is that kidney injury is relatively rare, and therefore contrast, when it's indicated, should be given basically most circumstances. The second one is one about gadolinium contrast, which we use for MRIs, and that is because in people with kidney injury, that was shown to cause a very rare condition called NSF, or nephrogenic systemic fibrosis, which is basically a horrible fibrosing disease where your viscera and skin can contract and fibrose, and you can die. It's extremely rare, and basically with the newer agents we use now today, it's unheard of. It does not occur. And so a couple of years ago, we actually changed the policies from these papers that basically that you can get contrast. Basically, even if you're on dialysis, you can get it now, which was not true for many, many years. And so again, a lot of people think they cannot get contrast if they need it. Not everyone needs it. But let's say you have a possible mass lesion, you want to characterize it to see if you think it's cancer or not, and contrast would be very helpful, then you should get contrast. You should get it. It's going to make a huge difference in the accuracy of that test. And so one of my personal crusades when I give talks to clinicians is to discuss the state of the art now with contrast agents, because it's a huge, I think, completely misinterpreted bit of science when it comes to safety.
What important truth do very few of your colleagues agree with you on?
I don't know if very few agree with me, but I would say that one of the things I believe, 2 things. One is that the money is the least important part of your job. I think is probably a lot of people don't agree with me on, but I think that the non-measurables of things are very important. So I think there's an idea of what's called the motivational hygiene theory of satisfaction. And so how much you get paid is a hygiene factor. Hygiene factors make you not hate your job. They don't make you love your job. What makes you love your job is the motivational factors. It's things like the intrinsic value of what you do. So I think the money is the least important part of your job. And the other thing that people don't always agree with me on is that I think the proofreading and the grammar and the word choice and the diction is really important in a radiology report. I think when I write a radiology report, that report is a proxy, again, for how much I care about the patient, essentially, right? And how much attention I put into it. So when you have a sloppy report, it makes the work look sloppy. And I think that even if you're a good radiologist with your eyeballs, you have to be a good radiologist with your communication too. In a role where patients see the reports, I think it's really important for radiologists to put the extra effort in to make the report as good as possible on every single angle and polish that report. And a lot of people just don't do that.
On your blog, you list out all the books you've read in any particular year. You've been doing this for a little while now, and you read a lot. So what is the best book you've read in recent memory and why?
Oh, that's a great question. So I'll say for nonfiction, I think one of the best things I've read recently is Atomic Habits by James Clear. It's a very popular book. I think it's the most popular book in the world right now. But it's basically a very tactical book about habit formation. And I don't think I follow like half the things he talks about. But I do think it's one of those great books that helps people take a look at their behaviors in a practical way to really see if they're getting value from what they're doing. For fiction, I can't do it. It's just too hard.
All right. Well, next time you come on the podcast, you'll bring a fiction book. Well, thank you so much for joining us today, Ben. It's been a real pleasure talking to you. For people who are just listening and will go and look you up afterwards, where can they find you on the internet?
So my website is benwhite.com, and I'm on Twitter at benwhitemd. And one thing I've written is my second book is a book about student loans, about managing that kind of debt, personal finance and whatnot. And that book is available totally for free. So the entire full text is available online. So for any medical student or resident or doctor or even non-doctor who is interested in personal finance from a perspective of a kind of doctor or young professional, it's a real book-length book that you can just read online.
It's an excellent book. I highly recommend it. I know that we didn't have time today to discuss it, but if you are a medical student, you should definitely take a look at this book. Thank you once again. We really appreciate you taking your time to join us, Ben.
Yeah, thanks so much, Ben.
If you'd like to support us, here are some ways you can help. Subscribe to this podcast wherever you get your podcasts. Leave us a review, preferably a phenomenal review. Visit us at externalmedicinepodcast.com and tell your friends.